They asked me to talk about surgical options for epilepsy, but this is generally what I think patients think about what I talk about. And this is the general thing: is you guys are all so far away. I don't bite. The small crowd, and you're like all at the periphery.
It's like church.
Right? Right? 'Cause typically, you're scared of a surgeon. That's fine. Hopefully, after this, there'll be a little bit less fear here. So, just as an outline, I was going to talk about the burden of epilepsy, as you all know, but some of the numbers as why we as surgeons care about it so much as well. Then, what types of epilepsy do we really focus on? Drug-resistant epilepsy and what that means. And then the meat of this presentation is really about the surgery and the options, different surgical options that do exist today. And then this doesn't have to be terribly formal. If you have a question, just raise your hand, shout out, yell at me, whatever. That's fine. So again, epilepsy is the fourth most common neurological disorder in the United States, as we heard earlier this morning. 150,000 new cases diagnosed annually. And so these stats we hear all over and over again. So very common disease overall. What makes it difficult for us as clinicians certainly is that epilepsy is one of those diseases defined by the symptom of seizures. And seizures can certainly be caused by a number of problems, whether it be a tumor, a bleed, a stroke, metabolic disorder, or idiopathic, something just inherently within the cells of the brain. And so that makes epilepsy extremely diverse disease, which makes diagnosis a little more difficult. And there's a session about the different types and diagnoses of epilepsy now, I know, and makes my job very difficult in the regard of making sure that diagnosis is appropriate and applying the right therapy for the right patient. So I've always been extremely big on patient selection. Now, burden of epilepsy, the morbidity is estimated to be approximately 10 years of life lost. And that's not only from the seizures themselves, but from everything else that comes along with the epilepsy, whether it be memory, attention, concentration, mood disorders, sleep, migraines, cardiovascular disease, all these things that can, on average for each patient, is approximately 10 years of life lost with persistent seizures. Now, even worse, and these are the numbers that I really focus on, is that if you're going to try to advocate for something as drastic, as you will, as surgery, what is the risk-benefit ratio there? So the way we see it and then what the numbers show, this was a paper published by Dr. Sperling at our institution, in that the mortality rates are 2 to 5 times higher in patients with persistent seizures, specifically those with persistent tonic-clonic seizures. So we're talking about if you have uncontrolled seizures, your chance of death are 2 to 5 times higher than without. So in our minds, if we can cure you of your seizures, or even get rid of your complex, or got rid of your tonic-clonic seizures, we've already decreased your overall mortality, right? So we're talking about high stakes here, which is reason to talk about surgery. Now, if you can certainly control your seizures with medication alone, that's fantastic. And unfortunately, in about a third of patients with epilepsy, that's not possible, unfortunately. So I'm not advocating for surgery for everybody. It's those that fail medical treatment. So, yeah, go ahead. Yeah, go for it.
One of the things that wasn't in your risk factor for why the increased morbidity, wouldn't it be just because you're taking so many medications?
That's true as well.
Right, so
yeah.
you would be eliminating the medications with the surgery.
So
you're saying
that's also something that you have to be a little careful about. So medication management after surgery, right? You may or may not reduce the medications. Sometimes you are, and that's great. We actually don't tend to touch the medications for at least 1 year after your surgery. And the way that we always like to think about it is that what I'm going to be talking about here, drug-resistant epilepsy, it's epilepsy that continues to persist even with medications. A lot of times what we do is we convert drug-resistant epilepsy to drug-responsive epilepsy with surgery. So we may still have you on your medications. Now, in some patients, yes, you may be able to come off your medications, but that's not everybody, okay? You're welcome. So drug-resistant epilepsy is defined by the International League Against Epilepsy as epilepsy that persists despite adequate trials of 2 or more, we always say 2, tolerated, adequately chosen, appropriately used anti-epileptic drugs. So if you've tried 2 medications that haven't been able to control your seizures, then you are considered drug-resistant. And that's something that not everybody knows. Even neurologists, family doctors out in the community don't know that so much, because on average, the patient that I operate on has been on about 8, 9, 10 different medications by the time they see me, which is always a little disheartening for me. And we say this because when you look at the numbers, and the graph on the bottom right there shows that the chance of seizure freedom with your first medication is almost 50% chance. When you try that second one, it goes down to about 10%. By the time you try your third or more, the chance of achieving seizure freedom is less than 5%. So by just trying different medications, your chances of actually getting seizure freedom are extremely low, and that's why it's really defined as once you've failed 2 medications, you should really start thinking about surgery. I always like this is from Scrubs, if you remember it. This is what people think of when they think of brain surgery, right? So this is what when we think about drug-resistant epilepsy, we think about, okay, what are the surgical options, okay? And so that's when we encourage you to say, hey, think about surgery. And just because you go talk to a neurosurgeon doesn't mean that you're committing to surgery, okay? Getting information, seeing what it's all about doesn't hurt, right? This paper is one that always baffles me and that I always have a hard time with. So this, as we know, epilepsy does have a strong stigma with it. And so this paper looked at the stigma not only with epilepsy but with surgery. And on the left, there's certainly the information regarding the stigma of epilepsy, but in these 100 patients polled, they were also asked a question. They were asked, basically, if someone could perform surgery, brain surgery, that would cure your epilepsy and at the same time be of no risk, would you do it? And half of people said no, which to me is shocking. Someone saying that we can cure you with no risk, and they say no. So there's certainly a stigma against brain surgery. And that's something I certainly struggle with on a day-to-day basis, not only with my epilepsy patients, my movement disorder patients, my pain patients, all this, because a large part of what I do is completely elective. You don't have to do it, right? But the reasons to do it, I'm not saying, I certainly enjoy what I do, but I'm not going to ask you to commit to something just because it's fun for me to do, right? I'm looking out for your best interest. And again, I'm going to emphasize this even more. The reason that we recommend surgery is because when you look at the risk of surgery versus the risk of persistent epilepsy, it's certainly a lot more favorable to go through surgery in certain situations, right? So in a series of over 2,000 craniotomies over 5 decades, there was a less than 1% chance of death in a series that was done across multiple centers. At Jefferson, there's been no deaths from over 700 temporal lobectomies done over the past several years, okay? Meanwhile, when you look at SUDEP numbers, 8 to 17% of deaths of people in epilepsy.
What does SUDEP mean?
Sudden unexplained death in epilepsy. So this is, I like analogies. So this is, when we think about what we think about surgery, neurosurgery these days, let's look at what we think about air travel, right? So this is the Wright brothers. This is what we were in the past. Most people don't think that that's what we do right now. Most people are pretty much in agreement that this is what air travel looks like today, right? You get on a Boeing or a Airbus, and it looks like that. In the future, I'm also a big Elon Musk fan, so SpaceX maybe will be going back and forth extremely quickly in shuttles instead. Now, if I were to ask people what they thought of air travel, most people would say, yeah, this is where we are right now, right? And people are comfortable getting on planes. I know there are some people that still don't like air travel, but the majority of people will get on a plane and go visit family, go on vacation, and so forth. Now, for neurosurgery, this is the past. These are the operating theaters of the past where you had, minimal sterile technique and lots of observers, and, that's how things were done. This is my operating room at Jefferson. A lot of high-tech equipment in order to perform the surgery in the safest way possible, and deliver the best care that we can. And the future is actually not too different, but more bells and whistles are certainly coming along. But my perception at least, and you can correct me if I'm wrong, of those in this room, is that I think most people would think that this is where we still are with surgery. And so I'm gonna, during this next, little bit, try to rectify that a little bit, at least for those here. This is another part of what I do, and try to better understand what's going on inside the brain through imaging, so we understand all the different parts of the brain. And I think this is another piece of why that stigma with brain surgery exists, and why it doesn't necessarily exist with other types of surgery. Getting surgery for a knee replacement, a broken bone. If I would ask that same question of, hey, I can fix that broken bone with no risk, would you have it done? You think 50% of people would say no, right? So I think it's that black box and that lack of understanding and that fear of, are we gonna change who you are by doing brain surgery, that is that hurdle for patients. And that's understandable. And so the more we can do to understand what's going on inside the brain, I think will help close that gap a little bit. This is the main message. Epilepsy surgery is safe, as this patient can very much attest to. This is not one of my patients, but we do also do some awake surgery at Jefferson, and it is well tolerated for the most part. So I'm gonna start from the way we think about surgery. We usually will first think about, can we safely remove the piece of brain that we think is causing your seizures? And if we are able to do that, in general, the chances of making you seizure-free are approximately 60 to 70%. And the picture that I have here is of a temporal lobectomy, which is our most common surgery, because very often seizures that do start in the temporal lobe can be treated very effectively with a temporal lobectomy. So these are our numbers, and for in each part of the brain, it is a little bit different. And this is 5-year outcome, 5-year outcome. So in temporal lobe epilepsy, if we are able to do a temporal lobectomy, approximately 2/3 of patients are seizure-free at 5 years.
And without medication?
That is not split out in this number. So some of these patients are on medication, some are off. That number is a lot harder to parse out for sure. Occipital and parietal lobes, the back of the brain, a little bit more difficult to control. 46% though still seizure-free. So you're talking about almost half of patients still being able to be seizure-free. And then frontal lobe is, again, harder. About 30% of patients remain seizure-free at 5 years out. This is certainly one way of treating seizures in terms of removing parts of the brain through open surgery, where we would have to make an incision, remove a piece of bone, take out that piece of brain before replacing the bone and closing everything back up. This has been tried and true. This is decades of experience and decades of understanding of how to do this and what happens. This is a newer technology that everybody asks about, laser ablation. Now, we were part of the initial laser ablation trials back in 2011, 2012. And what that is that instead of taking out a piece of brain, what we're doing is we're putting a laser probe that is able to heat the small portion of brain that basically burns it, and so that dies away. And so that's done through a very small hole. I'll go through this workflow very quickly, but instead of doing a big incision, what we do is that we have to get a image beforehand so we can plan where the laser goes. On the day of surgery, you do have to have this frame placed on your head, and as you can see here, fairly well tolerated. This is one of my patients. And that gets converted over to this device, which is a frame that lets us target that specific part of the brain with 1 millimeter accuracy. So we're talking about very, very accurate surgery. That's placement of the laser probe, and that's what it looks like actually in the operating room. That's it, just a small hole. This hole that we have to make is about 3 millimeters as opposed to a big incision. And that allows us, at the bottom here, you see the laser probe. This is for, again, temporal lobe epilepsy in this scenario, okay? And so what we're able to do is that with the technology that we have, we can actually do this burning of the tissue in real time. We see this happening on the MRI scanner, and we're actually able to control the ablation very precisely to a degree of a millimeter or two as we watch it happen on the MRI scanner. So it's extremely safe in that way, okay? So we're able to target these deeper parts of the brain here. This is the hippocampus, which is usually responsible for epilepsy a lot of times. And we're able to ablate that part of the brain with a very small hole. Nice thing about this type of surgery, people go home the next day. I've had a patient go back to work 3 days later. And the outcomes are pretty good. And why I say pretty good is that they're not quite as good as an open craniotomy. And as you'll see as I talk about different procedures, even though they may get more and more high tech, the efficacy drops a little bit. So laser ablation, 6-month and 1-year follow-up only, not 5-year plus, because it's a newer technology for sure. You're talking about 50 to 60% seizure freedom. So you're talking about 50 to 60 versus 60 to 70 in the lobectomy range. Now, the nice thing about laser ablation is that certainly you can have this done, and if it does not work, it does not prevent you from being able to do a temporal lobectomy. The big tenet of what we do in terms of surgery is we always want to take out, to your point, as much brain as possible to maximize your seizure freedom, but we can't take out so much brain that we leave any significant deficit, that we change you. We don't want to change you, right? So we know a lot about the brain, and so we know what we can and we cannot take out. And so if we can, we always advocate for doing the procedure that has the highest chance of giving you seizure freedom. But if it becomes unsafe for whatever reason, that your seizures are coming from the areas that are important, like the areas that control one side of your body or the areas that control speech, we're certainly not going to recommend taking that piece of brain out. Little graphic, but this is what we do to try to figure things out sometimes, or at least what we used to do, right? This is what was in the past. So this is why people are still scared of surgery, is that they see things like this, right? This is electrodes on the brain in order to identify where seizures are starting from, as well as where important parts of the brain are, like movement, speech, and so forth.
Is it the top of somebody's head?
That's the side. Yeah. These days, we have a newer technology called stereo EEG, where instead of a big grid like that, we put in electrodes that are 0.8 millimeters in diameter in. So the holes that we drill, again, 2 millimeters wide. So this is actually, as a comparison, this is the old way, this is the new way. We don't actually open things up. Everything, it's almost like a needle procedure, where we put the electrodes in through these little holes. As you can see, this patient had a prior surgery, and what he and other patients that may have had both this sort of monitoring and this sort of monitoring say is that this is very well tolerated. Most of my patients that have the newer monitoring, they have a headache for a couple days, and then during that monitoring phase, which has to happen in the hospital in order to map the seizures, they feel like they're normal, right? So newer technology to make our ability to identify where seizures are coming from certainly not only safer, but more comfortable. And this is the safer point, and this is why I advocate for it, is that SDE stands for subdural electrodes, which is that big, horrific picture you saw, versus SEG, where those little thin electrodes that we're now putting in. Oop. And if you look down the list of all the risks, we've now, by switching over to the method, the risks were not super high except for infection and hemorrhage. Hemorrhage is never a good thing. That means bleeding, right? But now all of that is within the 1% or less range with the newer technologies. So again, everything is certainly moving in the safer direction. So again, repeating that while we do want to be able to resect parts of the brain in order to give you seizure freedom, in those that are drug resistant, we're actually able to do that for almost 2/3 of patients. So that leaves some patients behind where even surgery cannot help. And that actually spans to upwards of 15 to 40% of patients with epilepsy, unfortunately. So what do we do for those people? So that's when we start talking about even newer technologies, things like neuromodulation. And what that means is electrodes in or on the brain or on nerves. So the first one I'll talk about is responsive neurostimulation, that you may know as the NeuroPace device. It's for patients that are 18 years or older with partial onset seizures that average 3 or more disabling seizures per month. You have to have drug-resistant epilepsy. As you can see, I've worked down this kind of algorithm of medication, then resection, then maybe laser, kind of put together, mapping, then what do you do? So then we talk about responsive neurostimulation. So let's see if this video will play. This is a video from NeuroPace, and it shows that the device is actually implanted within the skull. It sits in, so it's flush with the skull, and it's connected to 2 electrodes, and this is why it's only indicated for patients with no more than 2 regions of seizure onset. And what it's showing here is that it's like a pacemaker for the brain. It records from the brain, and then when it detects a seizure like that, it sends back stimulation to stop the seizure. And we work with the neurologists to program the device and tweak it so that the programs are optimized so that not only is the detection optimized to be able to pick up on each of the seizures, but also so that the stimulation parameters are also optimized in order to stop that seizure. So this has now been around for a few years as well. We've implanted nearly 40 or 50 of these. And in terms of outcomes, now when we talk about neuromodulation, we talk a little bit more about seizure reduction and a little less about seizure freedom. Because when you look at the true seizure freedom numbers with something like this, we're talking about 15%. But at the same time, you're talking about 70% seizure reduction, and that's cumulative over time. So that in the beginning, that may only be about 40%, but that over time, that can increase out to about 70% after 5 or 6 years. So it takes a little more time, but still better than nothing, right? Definitely having 70% fewer seizures that also does help in that equation of reducing your overall risk, overall morbidity, overall mortality. What about deep brain stimulation? Now, there's a caveat to this. This is not FDA approved yet, probably coming around the corner within the next couple of years. It is currently approved in Europe, so a lot of our experience is from the European group, although we were part of the what's called the Sante trial, or the stimulation of the anterior nucleus for the thalamus. This is the therapy I was talking about for epilepsy. And that was done in 2012. And in that trial, again, when you look at seizure freedom numbers, again, going down, 6% seizure freedom, but approximately 40% mean seizure reduction, okay? Again, because this is kind of you're targeting this central hub of the brain, but it's not really customized to one patient. Whereas when you talk about something like responsive neurostimulation, that is customized for each individual patient, which is why we think to some degree that's has a little bit more benefit. Now, finally, vagal nerve stimulation. I know we have Livanova here today, and you can talk to them more as well. And we also have NeuroPace here today, right? But vagal nerve stimulation is the one epilepsy surgery I do that's not actually intracranial. It's in the neck. And the way we do it is that we find a vagal nerve, which runs in the neck, and we put an electrode around it, and that gets connected to a battery that sits on your chest wall here, just like a pacemaker. The reason this works is because more than 80% of fibers in that nerve actually go up to the brain, as opposed to down out to the body. And there have been a number of studies, this has been a therapy that's been around for a long time, that certainly have been shown that vagal nerve stimulation decreases EEG synchronization, so decreases seizure synchrony and increases seizure threshold. It's been approved since 1997, so one of our oldest neuromodulatory therapies for sure, and it's approved for partial onset seizures. Now, again, looking at the data, you're looking at 44% mean seizure freedom, so similar to the DBS, and the numbers vary around between 40 to 50% mean seizure reduction, which is, again, great, especially in a patient population that has a very difficult time with seizures. There are some patients that benefit from seizure freedom, but again, it's on the lower end. So this is a summary of all of that, and why would I be crazy enough to say, hey, why don't we go for a resection and take out a piece of your brain rather than just do a little stimulator, that's a little less invasive. It's not because I'm trying to do the most invasive thing, it's because when you look at the outcomes and the chance of seizure freedom, that removing that part of the brain is giving you the best chance of cure. We're talking about because by the way, when you talk about these neurostimulation effects, there's almost no chance of coming off the medications. I'm never going to say never, because I'm sure there's some patients that do, but very, very little. So, as you can see, there's a lot out there, and it's very confusing. And because epilepsy is so different, and there's so many types of epilepsy, and they can be caused by so many different things, and there's so many different treatments. You hear about lasers, you hear about stimulators, you hear about medical marijuana, you hear about all these things. This is why you're here. Talk about it, learn about it. There's no harm in that. And what there is to know is that surgery is safe. We've been doing it for decades now. It's not like we're pulling you into my garage and saying, hey, let's treat your epilepsy. And it can cure epilepsy. So don't be afraid to talk to your neurologist or that scary neurosurgeon about it, because that doesn't necessarily commit you to surgery, but just at least find out more. And who knows, if you feel like your benefit will be worthwhile, then you know that the risk that is involved in brain surgery these days is low. I'm never going to say never. Things always happen. But we would never advocate for something that risk-benefit ratio was not in your favor. Thanks. Now we can open it up.